So if you take a standard aspirin right now, your body will, it'll flush it completely out of your bloodstream in about 20 minutes.
Right, 20 minutes.
And this is the crazy part, that single pill will physically alter your blood cells for the next 10 days.
Yeah, it's wild to think about.
And then on the flip side, you have a potent painkiller like methadone. It might stop relieving your pain after just like 6 hours, but it secretly lingers in your body for days.
Which is a huge hidden mismatch.
A mismatch that has actually fueled a major public health crisis. I mean, we take these instructions on our pill bottles totally for granted, right? You know, take once a day, take every 4 hours.
We just blindly follow the label.
Exactly. But those simple labels are hiding this really complex, invisible world of mathematical decay.
Yeah, and it is entirely invisible to the patient. But understanding that underlying math isn't just academic trivia for nursing or medical students to memorize for some exam. It is the quantitative backbone of safe medication. Whether we're calculating insulin schedules, setting antibiotic dosing intervals, or, trying to figure out why missing a dose of one drug is a non-event.
Well, missing another is like a total medical emergency.
Exactly. It all comes back to a concept called drug half-life. And, well, knowledge is most valuable when it's understood and applied. And today we're looking at how clinicians actually apply this math to keep you safe.
Yeah, we've got a fascinating stack of clinical pharmacology notes, historical medical papers, and pharmacokinetic research right in front of us. And the mission for this deep dive is to demystify those numbers on the side of your pill bottle.
Absolutely.
We're going to explore steady states, dosing intervals, and really why timing a dose is quite literally everything. So, okay, let's unpack this, because before we can understand how drugs work in your body, we actually have to look at where this concept even came from.
Yeah, the history is super interesting.
Right, because looking at the sources, it apparently wasn't even cooked up in a pharmacy.
No, not at all. The origins actually lie in early 20th century physics, specifically the study of radioactivity.
Wait, radioactivity, like glowing green rocks.
Well, yeah. I mean, if you look at the research of Ernest Rutherford and Frederick Soddy around like 1902 to 1907, they were studying how radioactive isotopes decay over time.
Okay.
And they were the ones who first defined the concept of a half-life, or T1/2, as you'll often see it written in clinical math.
Which sounds completely unrelated to, swallowing a Tylenol for a headache.
Yeah.
How did we jump from glowing uranium to pain relief?
Well, exactly how radioactive elements decay turns out to be the exact same mathematical model for how your body eliminates most foreign substances.
Seriously?
Yeah. Rutherford and Soddy basically discovered exponential decay. So the core definition of a drug's half-life is simply the time required for the concentration of a drug in the blood plasma to fall by 50%.
Okay, so just having it.
Right. If the mathematical curve for a radioactive isotope decaying in a lab looks like a clean downward exponential slope, well, the curve of a drug clearing from your bloodstream looks mathematically identical.
So let me make sure I've got this. If I have like 100 milligrams per liter of a drug floating in my bloodstream and its half-life is 4 hours,
Yep.
I'm just having that number every 4 hours.
Yeah.
Like at hour 4, I'm down to 50 milligrams.
Yeah, exactly.
And then at hour 8, I'm at 25 milligrams, then 12.5, then 6.25, and it just keeps dropping by half.
That is the fundamental mechanism, yeah. But translating that physics equation into human biology, that actually required a massive conceptual leap.
I bet.
We really owe that to a Swedish physiologist named Torsten Terrell.
Right.
So in 1937, Terrell published this 2-part paper that radically reframed how we even think about medicine.
How so?
Well, before his work, the medical community's primary question was totally binary. Just, does this drug work?
Simple enough.
Right. But Terrell shifted the paradigm entirely by asking, where is this drug, quantitatively, at every single moment after it enters the body?
Oh, wow. Which is such a brilliant shift in perspective.
Yeah.
But the sources actually note his work was largely ignored for decades. Why wouldn't doctors jump all over this?
I mean, the sheer complexity of the math was a massive barrier.
Oh, because they didn't have computers?
Exactly. Terrell was building these intricate mathematical compartment models to track the drugs movement, and he was doing the matrix calculus by hand.
Yikes.
Yeah, decades before computers were available to run those simulations. He fundamentally changed the model of the human body from, like, a static vessel to a highly dynamic system.
And there was another guy too, right? Widmark.
Oh yeah, Erik Widmark, another Swedish scientist, a chemist. He was actually doing similar mathematical modeling for blood alcohol concentrations even earlier in the 1910s and 20s.
That's fascinating.
And Widmark's equations are still used by forensic toxicologists today. But Teyerell was really the one who formalized the idea of the body as a system of interconnected tanks.
I really love that visual because we so often think of our bodies as just a single bucket. You swallow a pill, it drops into the bucket, the water sloshes around, and eventually the bucket empties.
Right, the bucket model.
But Tyrrell is saying, no, you are a complex plumbing system. You've got the stomach tank flowing into the blood tank, which then leaks into the fat tissue tank, which filters through the liver and kidney tanks. And each of those pipes has a completely different flow rate.
It's a great analogy. That interconnected plumbing system is the very foundation of what we now call pharmacokinetics, which researchers like Gerhard Levy and Milo Gibaldi finally brought to the bedside in the 60s and 70s.
Okay, and tell me if I'm wrong here. If I'm an ICU nurse juggling 5 different patients,
right,
I am absolutely not doing natural logarithms by hand at the bedside.
Definitely not.
Right. I'm not calculating when a drug will clear from my patient's blood tank with a matrix.
Yeah.
So how is this actually applied in the real world without a graphing calculator?
Clinicians actually rely on a foundational shortcut called the rule of 5.
The rule of 5.
Yeah. It is the single most clinically useful application of all this exponential math. The rule of 5 basically states that it takes roughly 5 half-lives for a drug to reach what we call steady state during continuous dosing.
Okay.
Or, conversely, to be effectively eliminated from the body after you completely stop taking it.
Let's walk through that because, 5 feels like an arbitrary number. Why not 3 half-lives or 10?
It comes down to where that exponential curve flattens out into clinical insignificance. So, as we established, after 1 half-life, you have 50% of the drug remaining.
Right.
After 2, you have 25%. After 3, 12.5%.
The halving math again?
Exactly. By the time you reach the 4th half-life, you're down to 6.25%, and at the 5th, you're at 3.125%.
Oh, okay.
At that point, roughly 97% of the drug has been cleared. And for the vast majority of clinical applications, that remaining 3% is functionally negligible. The body has effectively eliminated it.
And the sources say this same rule of 5 applies in reverse. Like when you are trying to build a drug up in your system.
Yes, the math completely mirrors itself. When you take a medication repeatedly at a fixed interval, the concentration in your blood doesn't just keep climbing infinitely, right?
Unless you're overdosing.
Well, yes, but at a normal dosage, it rises toward a plateau. That plateau is the steady state. It's the point where the amount of drug you're putting in exactly equals the amount your body's eliminating during that same time frame.
Got it.
And because of that exponential math, it takes about 5 half-lives of regular dosing to reach that steady state plateau.
Wait, I have to push back on this because it feels completely counterintuitive.
How so?
Well, if I want to get to that steady state plateau faster, can't I just take a much bigger dose?
Yeah.
Like if my doctor says take 10 milligrams a day and I double it to 20, shouldn't I hit the plateau in half the time?
That is a super common misconception, actually, but the math doesn't support it at all. Yeah. A larger dose does not reach steady state faster. It merely reaches a higher steady state.
Oh, wow.
So if you double the dose, your blood concentration will ultimately plateau at a higher level, but it will still take exactly 5 half-lives to get to that new, higher plateau. The time to steady state is entirely governed by the drug's half-life, completely independent of the dose size.
Okay, but wait. If a drug has a really long half-life, and it always takes 5 half-lives to reach a therapeutic steady state, isn't the patient just suffering in the meantime?
That's the real problem.
Yeah. Because if I have a serious condition today, I do not want to wait a week for my medicine to finally reach the effective level.
This raises a really important clinical question, and it's precisely why clinicians utilize what are called loading doses.
Loading doses.
Right. The sources highlight digoxin as a prime example of this. Digoxin is a medication used to treat heart failure and irregular heartbeats. And in a patient with normal kidney function, its half-life is roughly 36 hours.
36 hours. Let me do the rule of 5 math on that really quick. 36 hours times 5 half-lives. That's 180 hours.
Yep.
That's 7.5 days.
Which is completely unacceptable for a patient experiencing acute heart failure symptoms.
Right.
If a physician just prescribes standard daily doses, that patient would be waiting over a week for the drug to slowly climb that exponential curve just to reach a therapeutic steady state.
So what do they do?
To bypass this, clinicians administer a large loading dose upfront. This massive initial dose basically front-loads the body. It instantly forces the blood concentration up to the therapeutic plateau on day one.
That makes sense.
And then from then on, the patient just takes smaller maintenance doses. And those are mathematically calculated to replace exactly whatever the body eliminated over the past 24 hours, keeping them perfectly balanced on that steady state plateau.
Okay, that makes perfect sense for getting the drug into the system.
Mm-hmm.
But the sources highlight this really terrifying scenario where this exact same math can silently change and cause major harm. So digoxin is cleared almost entirely by the kidneys, right? What actually happens if that patient suddenly gets a severe kidney infection or an acute kidney injury?
Well, the foundational math just collapses. If the kidneys lose their filtering efficiency, digoxin isn't excreted at the normal rate anymore. Its half-life stretches from 36 hours to somewhere between 3.5 and 5 days.
Oh, wow. So the patient's internal clock just slowed way down.
Exactly. And this is where it becomes a literal matter of life and death. The maintenance dose hasn't changed. The patient is still taking the exact same daily pill that was perfectly safe last week.
But the body isn't clearing it.
Right. Because the half-life has drastically lengthened, the body is no longer clinching the daily input, the steady state is totally lost, the drug begins to accumulate slowly and silently climbing toward toxicity.
All because the underlying physiological decay rate changed.
Exactly.
That is wild to think about. The danger is completely invisible to the patient.
Yeah.
But here's where it gets really interesting, though.
Oh, yeah.
The rule of 5 works beautifully, assuming the drug actually follows these exponential rules. But the sources point out that some drugs are absolute rule breakers.
Very true. The clean exponential decay we've been discussing assumes the drug follows what we call first-order kinetics, meaning a constant fraction of the drug is eliminated over time, always 50% per half-life.
Right.
But there is a rebel category of substances that follow zero-order kinetics.
Zero-order kinetics. And the sources say this means instead of a constant fraction being cleared, the body clears a constant amount per hour, regardless of how much is in the system.
Exactly.
Which perfectly explains the classic drinking myth. People think they could just drink a pot of coffee or take a cold shower to sober up faster after a heavy night out.
Yeah, that doesn't work. Ethanol, or alcohol, is the quintessential zero-order kinetic substance. To understand why you can't just speed it up, you have to look at the actual cellular mechanism.
Okay.
So your liver uses specific enzymes, primarily alcohol dehydrogenase, to metabolize ethanol. But there is a finite number of these enzyme molecules.
Right.
Once they are all actively processing alcohol, the system is fully saturated. It is operating at absolute maximum capacity.
It's like a toll booth on a highway.
Yeah.
If the toll booth can only process, say, 1 car per minute, it doesn't matter if there are 2 cars in line or 200 cars in line.
Mm-hmm.
The throughput is a flat, constant rate. The heavy drinker just has to wait in line.
That analogy perfectly captures the bottleneck. Because the elimination rate is a flat, say, roughly 1 standard drink per hour rather than a percentage, the concept of a fixed half-life doesn't even exist for ethanol.
It makes total sense.
The time it takes to have your blood alcohol concentration changes wildly depending on your starting level. And alcohol isn't alone in this. High-dose aspirin and the anti-seizure medication phenytoin also follow zero-order kinetics.
Oh, wow.
Which is why a neurologist has to be incredibly careful adjusting phenytoin doses. A tiny increase in the dose can suddenly overwhelm the liver's enzymes, backing up the toll booth instantly and causing massive toxicity.
And it isn't just about how the drug is cleared, right? It's also about where the drug decides to hide. This brings us back to Terrell's interconnected plumbing system.
Right, the multi-compartment model.
Drugs don't just hang out in the bloodstream waiting to be filtered. They distribute through the body in phases, which the sources call multi-compartment kinetics.
Yeah, when a drug first enters the bloodstream, we typically see a very rapid drop in blood concentration, but this isn't elimination. This is distribution.
Okay.
The drug is moving out of the blood and permeating into tissues and organs. We call this the alpha phase. Once the drug has settled into those tissue compartments, we enter the beta phase, or the terminal elimination phase.
And that's when the liver and kidneys kick in.
Exactly, where they actually start removing the drug from the entire system.
Wait, so when I look up the official half-life of a drug in a medical textbook, which phase am I actually looking at?
You are almost always looking at the terminal beta phase.
Yeah.
However, That single number can drastically understate a drug's persistence in the human body, particularly if we are dealing with a lipophilic drug.
Lipophilic, meaning fat-loving.
Correct. Lipophilic drugs are highly fat-soluble. They easily slip across cell membranes and pack themselves into your adipose or fat tissue.
So they just sort of camp out there.
Yeah, and blood flow to fat tissue is relatively low compared to major organs like the heart or brain. So once a lipophilic drug gets into the fat, it essentially gets locked in a physiological vault.
A volt.
Amiodarone, which is a powerful antiarrhythmic drug used for irregular heartbeats, is a notorious example of this. Because it accumulates so heavily in fat vaults, its terminal half-life isn't measured in hours. It is measured in weeks and sometimes months.
Months? You mean a single dose takes months to clear?
Oh, yes. A patient who has been taking amiodarone and then stops can have detectable levels of the drug and remain at risk for its toxic side effects for up to 100 days after their final dose.
That's horrifying.
The drug just slowly and continuously leaks out of the fat tissue back into the bloodstream. If a patient develops, say, pulmonary toxicity from the drug or needs to stop it prior to a major surgery, the medical team is dealing with a substance that effectively refuses to leave the premises.
So asking what is the half-life and asking how long do I need to worry about this drug are two entirely different questions.
They require completely different clinical mindsets.
So amiodarone proves that a drug can physically linger in your body long after you stop taking it. But there's an even more dangerous scenario in the sources. What happens when the drug is physically gone, but the effect remains?
Oh, yes. To understand this, we have to separate two foundational concepts in pharmacology: pharmacokinetics and pharmacodynamics.
Okay.
Pharmacokinetics is everything we've been discussing, what the body does to the drug, how it absorbs, distributes, and eliminates it. Pharmacodynamics is what the drug does to the body, the actual physiological change or clinical effect it triggers.
And these two timelines can diverge.
In extraordinary ways.
Okay, this is the aspirin paradox I mentioned at the very beginning of the show. The sources say aspirin's plasma half-life was only 15 to 20 minutes.
Right.
Following our rule of 5, the drug itself is effectively eliminated from the blood in an hour or two. Yet, it prevents your blood from clotting normally for a week to 10 days.
Yep.
If the drug is physically gone from my blood in 20 minutes, how on earth is it still working a week later? Where is it hiding?
It isn't hiding at all. The drug really is gone. The prolonged effect is due to the specific mechanism of action it deployed during the brief 20 minutes it was actually present.
Okay.
Aspirin permanently inactivates an enzyme called COX-1 inside your blood platelets.
Wait, it permanently breaks the enzyme?
Yes, the inhibition is irreversible. And because platelets lack a cell nucleus and DNA, they cannot synthesize new COX-1 enzymes to replace the broken ones.
So they're just useless.
Those specific platelets are permanently impaired from clotting for the rest of their natural lifespan, which happens to be about 7 to 10 days.
It's less like a lingering guest in your house, and more like someone who walked by, threw a rock through your living room window, and immediately ran away.
I love that.
The drug is completely gone in seconds, but the broken window remains until your body physically builds a new one.
That is an excellent way to visualize irreversible enzyme inhibition. But if we connect this to the bigger picture, this mismatch between a drug's physical presence and its clinical effect isn't always a convenient feature.
It can be bad.
It can be profoundly dangerous. U.S. public health agencies have flagged this exact pharmacokinetic-pharmacodynamic mismatch as a key driver of the opioid overdose crisis, specifically regarding methadone.
How does the mismatch work with methadone? I know it's used for severe pain and opioid use disorder, but why is the timing so deadly?
It comes down to the patient's subjective experience versus the objective math. Methadone's analgesic effect, the actual pain relief the patient feels, lasts only about 4 to 8 hours.
Okay, but what is its elimination half-life? Like, how long is the drug actually in the blood tank?
The elimination half-life is highly variable, but it ranges anywhere from 8 to 59 hours.
Oh, no. I see where this is going.
Imagine a patient managing chronic pain. After 6 hours, the pain relief wears off. They are hurting, so they assume the drug is gone, and they take another dose.
Naturally.
6 hours later, the pain returns, they take a third dose. But because the physical elimination half-life can be up to 59 hours, the body hasn't even come close to clearing that very first dose.
They're just stacking new doses on top of a rising mountain of the drug in their bloodstream.
Precisely. They are unknowingly driving their plasma concentration higher and higher. The pain relief is gone, so their brain tells them the drug is gone, but the physical chemical is accumulating, silently pushing them toward the threshold of respiratory depression.
That's terrifying.
Patients and sometimes even prescribers fail to account for the fact that the drug's physical mass is still heavily present long after the clinical relief has faded.
That is incredibly tragic. But it really crystallizes why clinicians have to understand this math at a deep level. It's not just numbers on a page, it's human behavior interacting with invisible decay rates.
Absolutely.
Now, because this half-life number can be so misleading, there are intense, high-stakes debates happening right now in intensive care units about how to even measure it.
Yes, particularly in anesthesiology. In 1992, researchers Hughes, Glass, and Jacobs published a landmark paper introducing a concept called context-sensitive half-time.
Context-sensitive half-time, meaning the half-life literally changes depending on the context of how you give it.
Specifically how long you give it. They were studying continuous intravenous infusions, which are standard during long surgical procedures.
Like an IV drip.
Right. And they found that for certain lipophilic drugs, like the opioid fentanyl, the effective half-life actually lengthens the longer the IV drip runs.
Wait, how does running an IV longer change the drug's decay rate? Does the liver just get exhausted from processing it?
It goes right back to Terrell's interconnected tanks. When you start an IV infusion, the drug fills the blood tank and begins flowing into the peripheral tissue tanks, like muscle and fat.
Yeah.
If it's a short procedure, you turn off the IV, the blood level drops, and the patient wakes up. But if you run that continuous infusion for 6 or 8 hours, you eventually saturate those peripheral tissues. They are completely full.
So what happens when you finally turn off the IV after 8 hours?
The concentration of the drug in the blood drops rapidly, but now, because the peripheral tissues are fully saturated, a massive concentration gradient is created.
Meaning?
The drug begins flowing backward, it leaks out of the fat and muscle tissues and back into the bloodstream.
Oh, wow.
These saturated tissues basically act as a slow-release internal reservoir, artificially sustaining the drug levels in the blood. So, after a brief infusion, fentanyl clears very quickly. But after a prolonged infusion, its effective half-time can actually become significantly longer than a drug like morphine.
Which completely blows up the standard drug chart. I mean, a textbook might say fentanyl is short-acting, but in the context of an 8-hour surgery, it suddenly acts like a long-acting drug.
And this realization revolutionized how anesthesiologists choose between different drugs for prolonged procedures. It also ties directly into how we monitor patients in the ICU, a practice known as therapeutic drug monitoring, or TDM.
TDM, right.
For drugs with a very narrow therapeutic index, meaning the margin between a safe dose and a toxic dose is incredibly thin, like the antibiotic vancomycin or the psychiatric medication lithium, we have to draw the patient's blood to physically check the concentration.
But based on everything we've talked about, the timing of that blood draw has to be mathematically perfect.
The timing is everything. Clinicians typically want to measure the trough level, which is the lowest concentration of the drug in the blood, drawn immediately before the next dose is administered.
Okay.
But a common critical error is drawing that trough level too early, before 5 half-lives have passed and steady state has actually been achieved.
Because if you haven't hit the 5th half-life, the patient is still climbing the curve. The plateau hasn't leveled out yet.
Exactly. The number you get from the lab might look reassuringly low, but it's a phantom number. It doesn't represent the true steady state.
So the doctor might increase the dose.
Right. And if a physician increases a dose based on that premature, falsely low number, they could push the patient directly into toxicity once the true steady state finally arrives.
So what does this all mean for you, listening to this right now? Well, it means this complex, invisible math governs your everyday life and your everyday safety.
It really does.
If you were ever told by a surgeon to stop taking your blood thinner, like a Pixaban, exactly 3 days before a scheduled procedure, you now know that isn't a random guess.
No, not at all.
That is a clinician doing a rule of 5 calculation on your behalf to guarantee your blood will clot normally when the scalpel hits.
It also explains your daily habits. When sleep experts advise no caffeine after 2 p.m., they are referencing pharmacokinetic decay.
Wait, really?
Yeah. Caffeine has a half-life of roughly 5 hours in a typical adult. So if you drink a cup of coffee at 2 p.m., by midnight, 2 half-lives have passed.
Which means, based on our math, 25% of that caffeine molecule is still physically circulating in your brain, actively binding to receptors and keeping you awake.
And what's fascinating is that caffeine's 5-hour half-life is just a population average.
Right.
The sources note that it is highly variable.
Variable how?
Well, if you are pregnant, the half-life extends significantly. If you are a smoker, the half-life actually shortens due to enzyme induction. It is wildly dependent on your personal genetics and liver function.
Which leads to a really fascinating thought to leave you with today. Because right now, the entire medical system relies on these generic textbook half-life, these population averages printed on package inserts.
Right.
But what if, in the near future, we don't have to guess? What if you could swallow a smart pill or wear a biometric patch that constantly samples your interstitial fluid and calculates your personal pharmacokinetic decay rates in real time?
That would represent a monumental paradigm shift in pharmacology. I mean, imagine a clinical landscape where the rule of 5 isn't based on a historical clinical trial of strangers, but becomes perfectly customized to your exact metabolism, your precise kidney function, and your genetic makeup on any given Tuesday.
It would be revolutionary.
We could effectively eliminate the guesswork of dosing, preventing toxicity before it ever happens.
You would have a real-time dashboard of your own interconnected tanks right on your wrist. It is incredible to think about. Well, next time you look at a pill bottle and see take every 4 hours, you'll know there's a whole world of physics, saturated tissues, and exponential decay hiding behind that simple label. Thank you for joining us on this deep dive. Keep questioning the everyday, keep learning, and we'll see you next time.